So my objective is to discuss on when to operate on these distal radius fractures. Okay, now let me put it this way, when to operate, and then later I'll discuss the ways of conservatively managing it very well. Again, this is the same thing, repetition. So when do we operate? A very few indications for a distal radius fracture, not many. So when you have done an open reduction, when the fracture is open, there is a compound injury, and very unacceptable alignment is there. Probably that is the best situation, and then the fracture is very unstable, especially when there is associated distal ulnar association or distal radioulnar joint association, and coronally and rotationally it is very much malaligned. It's not acceptable. So sagittal plane deformities, any amount of deformities can be accepted, like the way we discussed about bayonet deformities. With the shortening of even up to 1 centimeter, it can be accepted. So it has been found by many research that if there is a distal ulna is associated with the distal radius fracture, they tend to be little unstable. You can try to manage them conservatively, but keep it in mind that then this can be unstable situation. And this is a bayonet fracture, same thing, bayonet displacement. This can be very much accepted. And as discussed by the previous speakers, that it's very important that, that we understand these fractures with respect to the alignment and other things. But whatever said and done, the maximum growth is given by the distal radius. It's about 90% of the forearm growth is coming from the distal portion, that is around the wrist. So the casting guidelines are stressed very well. I don't think so I have to go back. I think this is one area that we have to give importance, because a good cast can keep whatever deformity correction you have done very well. A casting index has been stressed already very much. And this is the same thing, again Dr. Told in the earlier talks. They are very much inherently stable. There's torus and buckling fractures. Smaller kids, I don't put anything, not even an arm pouch. I just tell them, don't touch that area. Probably within a week or two, they unite very well. At the most, you can give an arm pouch. I don't even put them in a plaster cast. They are quite stable. So when you're treating, if you observe this kind of an angulation, you still don't have to worry, because as I said, there is a remodeling potential so much. Younger the child, better is the remodeling. So the same fracture, you can appreciate how well it is remodeled over weeks. Very, very fast, even though they keep complaining that there is a deformity, what we have to do is just reassure the parents, tell them that it's going to be fine. And functionally, the kids will be fine. It's only the parents who are quite worried about the deformity. A few things about the physeal injuries. Again, we do see physeal injuries in the distal radius. It's about Salter-Harris type 2 is the one which is commonly involved. And if they come immediately, obviously we all do a close reduction and casting. And of course, morning we discussed with Dr. Vidyasagar's case about the vascular injury, nerve injuries which may be affected very rarely in the distal radius, but median nerve is one thing we have to look into in case of physeal injuries, because quite a bad deformity it produces. So non-displaced fractures, these physeal separations, you can definitely put them in a cast. You don't have to do anything. Displaced physeal fractures, you should undergo a close reduction, preferably under anesthesia. And most of the time they fall back. And up to 10 days probably. I mean, of course, these are all the periods which are described by each person in a different way. What we do is up to 2 weeks. We try to do it, but most of the time what I practice is more than a week. I tend to leave them alone. I don't do any manipulation. And I think with manipulation we'll be causing more insult to that area. And again, up to 50% of the malalignment in the 50% of contact is enough in the physeal injuries. You don't have to. There is a 2 years of growth remaining. That is sufficient. That the fracture remodels very well. So residual angulation greater than 20 degree will normalize substantially, but not always completely. So that we have to keep it in mind. There is some amount of a deformity may be remaining, but they don't cause much disability or any problem. So this is again the same example, physeal displacement, what we see commonly. These kids, especially when they come late, we don't do anything. Again, because of the fact that the distal radius contributes maximum to the growth and it remodels very well. The same with the remodeling. And again, distal metaphyseal fractures, again, they do very well if they are not with the distal ulnar fractures or a distal radioulnar joint that often. But if there is a metaphyseal fragment, quite a good amount remaining, probably you can consider for a fixation if they are unstable. Otherwise, still these can be treated with the closed reduction. Bayonet, as I said, they can be managed. Very rarely you may have to do a K-wire fixation. And one message is never cross the physis. Again, we all have learned about the K-wire fixation with the distal radius in adults, but in children, even this physis is contributing so much, the physeal scarring can lead to a very bad deformity. So there are ways of reducing this bayonet fracture with the minimal displacement. Both can happen, volar and dorsal. The same way considerations can be done. So I think this is the same message what I am giving. These are the fractures which are treated by K-wires, but make sure that if at all, if there is a situation you have to treat them with a fixation, make sure that the physeal plate is not insulted, because these are the growth plate disturbances which can result, and that requires a bad prognosis and then some other approach. To conclude my talk, this management is most of the fractures, avoid fixing through the physis. Above elbow, if on the age, and physeal injuries more than 10 days, better to avoid any kind of intervention. Operative intervention is used when only open injuries are in difficult situations.